Good day, everyone. My name is Clarissa. For today's event, we're going to continue to review the ESR of the SIBAI, specifically the ESR on QM or Quality Management and Patient Safety, namely QM17 and QM18. Now, the purpose of this activity is for us to correctly identify our patient using the approved patient identifiers and be able to employ measures that prevents wrong patient, wrong site, wrong surgery, or procedure. Now, at the end of this presentation, a task will be provided as part of your participation, and for any queries, you can always visit us at the Academic Affairs and Training. Okay, now let's have a quick review on the 20 ESR standards of the SIBAHE, starting with HR5, the process of staff credentialing, MS7, the clinical privileges for medical staff, PC25, handling, use, and administration of blood and blood products, PC26, DVT identification and management, then QM17, the process of correct patient identification, QM18, the process to prevent wrong patient, wrong site, wrong surgery or procedure, AN2, the anesthesia staff having an appropriate qualification, AN15, only qualified staff performing the moderate sedation or the conscious sedation. IPC4, that there is the presence of a committee that supervises the infection control. IPC15, isolation practices. MM5, this is the system for HAMS or high alert medication. MM6, system for LASA or the look-alike, sound-alike medications. Then MM41, medication error reporting. LB51, the process that prevents disease transmission by blood transfusion. FMS9, radiation hazard. FMS21, the effective alarm system. FMS22, the fire suppression available in the required area. FMS23, the fire exits are located properly. FMS24, the hospital and its occupants are safe from fire and smoke, and it has something to do also with the no smoking policy. And finally, FMS32, that the hospital ensures proper maintenance of medical gas system. Quality Management and Patient Safety or QM. This is Chapter 6 of the SIBAHE Manual, consisting of 25 standards with sub-standards and 2 ESR. Now, this chapter addresses the senior leaders and the hospital staff responsibility towards implementing programs that effectively improve quality and safety and reduce risk to patients, staff, and visitors. Now, to be able to effectively improve quality and safety of care and reduce risk, the hospital must constantly use indicators to measure its performance. Now, the hospital must also be able to identify significant unexpected or adverse events and intensively analyze them to understand the underlying causes and, as a result, make the necessary improvement interventions. Now, the required processes to improve quality and safety and to reduce risk, this includes a planned and organization-wide approach for quality improvement, the required structure, Quality and Patient Safety Committee, the Quality Management Department, the Quality Management Program, leadership and other staff quality concept education, data collection for structure, process, and outcome indicators of quality, prioritization and implementation of appropriate improvements, risk management, identification and analysis of significant events, patient safety program, and incidents reporting and management. Now, nurses, I want you to focus on the two ESR, QM17 and QM18 happens to be same with our IPSG. Our IPSG is in the International Patient Safety Goal. So QM17 and IPSG number 1 is the same, ensuring correct patient identification. And QM18 and IPSG number 4, ensuring or it's a process to prevent wrong patient, wrong site, and wrong surgery or procedure. So they are the same. Okay, now moving on to the first ESR under QM. So we have QM17. The standard states that the hospital has a process to ensure correct identification of patient. substandard states that at least two patient identifiers, example, we have the full name, medical record number, are required whenever taking blood samples, administering medications or blood products, or performing procedures. Then other substandard states that the hospital has standardized approach to patient identification, example, the use of ID bands with standardized information. And another substandards, patients are actively involved in the process of patient identification. Now, moving on to the policy that supports QM17, we have patient identification. This is the title of our policy with the following purposes: to establish an approach to reliably identify an individual as a correct person for whom the service or the treatment is intended, to match the service or treatment to that individual, to prevent wrong patient identification. All newborns will be accurately identified immediately after delivery. Infant abduction and discharge to wrong family will be prevented, and to minimize related medical errors and patient harm. Okay, now let's continue with the patient identification, specifically on the definition of terms. This is a 9 pages and I'm not going to discuss everything. I only highlighted some of the important things. So starting with ambiguous baby, this is infant whose genitalia cannot be clearly classified as either a male or a female. So there is a disorder in the sexual development of the baby. So a white wristband will be used until they are able to identify the sex of the baby. And that's the time you can change the ID color band into blue or pink one. Then we have adult patient is a male patient more than 12 years old or a female patient more than 14 years old. Then we also have here neonate, newborn up to 28 days old. Then pedia patient, we have male patient who's 29 days old up to 12 years old, and a female is a patient who is 29 days old up to 14 years old. Then we have unknown patient, patients who are not identified being comatose, incomprehensible, mentally handicapped, confused, or otherwise, and with no ID, relative, or companion. Now, patient's full name, this is 3 to 4 names or the complete name as it appears in their government-issued ID, like in the passport, ICAMA, or the family card. Now, I think this is not career because a career is a profession. I think this is a carer from the word care. So a carer is a British English which means caregiver. So this is a carer. Then we also have here OVR, of course, your occurrence variance report. Here they use ED as emergency department, not ER. So ED. Then we have MRN, the medical record number, and of course, OPD. Okay, now moving on to the responsibilities of patient identification. So starting with the nursing director and concerned staff, they are responsible in ensuring that patients are aware of the identification policy by means of appropriate patient information. Now, the medical director and concerned staff, they are responsible for ensuring that this policy is implemented operationally and monitored. Now, the department heads are responsible for ensuring that in their areas, they are aware and they understand the policy and that is implemented. And also they ensure that failure to comply with the policy, they are reported as OVR. Now for clinical and non-clinical staff, they are responsible that to maintain the standards and accept accountability for their practice and reporting all failures to comply with the policy through OVR. And then for the quality and patient safety department, it is their responsibility to review, monitor the implementation of the policy. Okay, now moving on to the patient identification policy. So it states in our policy that all patients must be correctly identified and matched with the records, investigation, and procedure requests, prescription results, and all other documents while being assessed and undergoing procedures or treatment in our institution. Now, it is the policy of our institution that all inpatients and any therapeutic procedure needed patient identification by using two identifiers. So the identifiers that we need are this. Now for Saudi adult and pediatric patients, we need patients 3 or 4 names and the medical record number. For non-Saudi adult and pediatric patients, again, we have patients 3 names as shown in the ICAMA passport. And then we have the MRN or the medical record number. Now, for neonates, these are the 5 details that we need. The mother's 3 or 4 names, the baby's medical record number, the sex of the baby, the nationality, the date and time of birth. Now, for patients in emergency department without admission, they will be identified by his or her name and their ID number. Okay, for clarification, please take note, quality nurse coordinator and supervisors of the nursing department, please continue to coordinate with the quality department, and for any update, please include it in our monthly unit meeting so that we can finalize the details of correctly identifying our client. Now, the policy states that in identifying a Saudi client and a pediatric patient, we will be using the 2 patient identifiers like patient's 3 or 4 names and the medical record number, and for non-Saudi, we will be using 3 names and the medical record number. Isn't it that we said before that when we are going to identify a Saudi client, we will be using 4 names, and for non-Saudi, we will be using 3 names plus the medical record number. Now, please clarify these things, because in the policy of site marking timeout policy, they verify or they check the clients. Specifically for Saudi, they use 4 names, and non-Saudi, they use the 3 names plus the MRN number. Now, for identifying the neonates, we have to use the mother's 3 or 4 names, the baby's medical record number, the sex of the baby, the nationality, and the date and time of birth. Now, during my rounds, these are the things that I have observed. The first ID band is written by the nurse, and again, they use 2 to 3 names for a Saudi client, and this is incorrect. And also, another one here, it's file number. It's file number. Why not MRN number? And added information, we have the age and then the sex of the patient. The second ID band is with the use of a barcode. Again, this is a Saudi patient, but they use 2 name of the patient, which is incorrect. And then we have here the gender. Okay, a while ago they used the sex of the word sex, and then here they use gender. And then we have here bed, which is leave as blank. And then on the other side, we have patient, the file number. And beside the file number, we have here the MRN number. Then another is the third ID band is vague. It's very unrecognizable. It faded already. And isn't it we said that when the ID band gets wet, becomes karban, or it's become unrecognizable, we have to change it right away, because this is the identifier of the patient. So when we give medicine, we usually check on these things. Then another ID band is for neonate. Now, first thing is that we make a temporary ID band because we need to secure a permanent MRN or file number for the baby. Since we still don't have, they usually take this information. So as we can see in this slide, we have 1, 2, 3, 4 names of the mother, and then we have the MRN of the mother, and it's written here, baby boy at 12:40 a.m. And then we have date, LSCS, and another number. But still, we need to standardize the written data based on the policy of our institution. Okay, let's continue. It is the policy of our institution that all emergency department and inpatient, they must wear the approved identification wristband containing 2 identifiers. Now, in case of multiple trauma and the extremities are affected, attach the identification band in the available limbs or place it over on the chest using a transparent tape. Now, in case of 2 or more patients have same or similar names and admitted at the same unit or ward, so that these are the following safety measures that must be implemented. So here, this is not 4. The 4 names, if available, will be added to the patient's name as identifier, and the patients will be placed in a separate rooms. Now, assigned staff will communicate during the handover process. I mean, you need to endorse this one or add to your endorsement. And then the information on the wristband must be checked with the family, patients, or guardian, carer, and medical records prior to application. And if the patient's limbs are too large, then 2 wristband identification bands may be joined together so that it can accommodate the large limbs of the patient. Okay, now moving on to color category of the wrist tags. So according to our policy, it states that the adult group inpatient, for male and female, we use the white wrist tag. Now for pedi group inpatient, the boy, neonate and pediatric, we will use the blue wrist tag. For girl, neonate and pediatric, we use the pink wrist tag. Now for neonates, we have to attach the wrist tag or the ID band on 3 separate limbs. So 1 in the upper wrist and 2 ankles containing the patient's 5 identifiers, and these include: number 1, mother's 3 to 4 names; number 2, baby's medical record number; number 3, sex of the baby; number 4, nationality of the baby; and last, number 5, date and time of birth. Now, for the high-risk color tagging for inpatient, it is stated in our policy that they will be coded with red strip in the middle of their respective wristbands. And the categories include high risk for fall, risk of developing pressure ulcers, allergy to latex, high risk medication, name similar to another patient, should not have blood drawn from his or her arm. An example of this one, we have those with fistula, and patient who will undergo hand surgery or procedure involving their hands. Okay, now let's continue with the emergency department color system. Now, for adult male and female, we will still be using the white wristband, but this time with yellow strip. Now, the Pedia boys, blue wristband with yellow strip. The Pedia girls, pink wristband with yellow strip. Now, the procedures requiring positive identification of patients includes blood sampling, blood and blood products transfusion, collecting of patient bodily fluid samples, confirmation of death, administration of medicine, surgical intervention and any invasive procedure, transport and transfer of patient, X-ray and imaging procedures. Now, patient without identification band must not be moved from one place or ward to another until the ID band has been supplied or fitted. Now, the patient must actively participate in all stages of the process of positive identification, and we usually use the open-ended question instead of the closed-ended question. So we have to ask the patient name, like, what is your name, rather than, are you Muhammad? Now, the patient will not be admitted to the operating room, receive medication, provide specimen, unless there is an identification band on the patient with verifying his identity. Another is all patients to be admitted for procedure for a brief stay, like in day case surgery or AQU and other procedure, they must be identified as inpatient exactly. That's our policy stated. And then in case of patient that is confused or unable to respond, the same explanation should be given to the family, guardian, carer, so that they will be made aware. Okay, now moving on to procedure. So every admitted patient has an approved identification band. And then the identification band will be renewed during the patient's admission if at any time the information shown on it becomes illegible. Illegible means unreadable, it's not clear, or cannot be read. Okay, on to the next. If the ID band is removed, faded, damaged, or unreadable, a new ID band shall be replaced immediately. Now, transfer between departments. Patients who are transferred from one unit to another should have their ID band checked as part of the admission or transfer process. Now, before administration of medication and blood products, the bedside check is a vital step in preventing transfusion error as well as medication error. So two healthcare providers should be responsible to do the independent double check by positive identification. Now, if you are not sure, do not give the medication or blood products until the patient is correctly identified. Now, before providing medication, treatment, procedure, or any diagnostic procedures for inpatient or in the emergency department, it is the responsibility of the sending nurse to ensure that the correct patient is sent according to the request that has been made, and it is the responsibility of the receiving healthcare provider to ensure that the correct patient is going to be examined according to the request that has been made. Now, the exposure or treatment must not be performed until correct patient identification has been verified. Now, for the pharmacist, dispensing of medication to the department is verified with the physician's order form. Now, for outpatients, the X-ray technician, sonographer, physiotherapist, and the pharmacist must verify the patient's identity by comparing the patient's verbalization or what the patient says in comparison with the written request form, appointment slip, or the prescription. Okay, moving on. Before taking blood and other specimen for clinical testing, so the labeling of sample and specimen container must be done in the presence of the patient at the time of collection. Do not attach the barcode or sticker to an empty container. The nurse will attach only after specimen has been collected. And do not delegate specimen labeling to another staff. Okay, now let's jump into the procedure of patient identification, specifically with emergency department patient identification procedure. Now, the patients in emergency department, not for admission, will be identified by his name and ID number. Now, in the event that the patient is admitted unconscious alone, the identification band should state unknown male or unknown female plus the medical record number if available. Now, all dead patients must be correctly identified, again using two identifications, one ID band attached to the wrist, and the other identification must be attached to the chest using transparent tape. Now, if the limb is missing, then attach one label to the available limb and other identification to be attached to the patient's chest using transparent tape. Now, if in the event that the patient's name not being known to the identification band should state unknown dead male or unknown dead female plus the medical record number if available. Now, for the newborn identification, as stated in our policy, it states that after the birth, temporary two wrist tag will be attached immediately to the baby with the following data mentioned in the nurse on duty on the area will be the one responsible in opening the admission file for the newborn using the request form for opening file that will be given to the admission office. Now, no infant will be transferred from the room who was born in without being labeled completely. In the delivery room, the one in charge with the mother will write 4 wrist tags. So 3 wrist tags for the baby and 1 will be attached to the mother. Now, for NICU nurse, they will write temporary 2 wrist tag. 1 will be attached immediately to the baby and the other will be attached to the wrist tag of the mother. Now, the data written to the wrist tags will be checked and verified before attaching it to the newborn, and the doctor attended the delivery will visually confirm the accurateness of the data written on the wrist tag. Now, the physician will sign, put a stamp, date, and time of the newborn's file identification form. Now, after complete verification, the nurse shall apply ID band on the right leg or left leg and one on either of the right or left wrist of the infant. And then with corresponding mother's name and MRN, gender, date, time of birth, and nationality. Now, the mother should have a matching ID band applied also at the time she delivers on her wrist for identification. Okay, let's continue with the newborn identification process, specifically with newborns delivered at home. Dispensary car or ambulance shall be immediately identified upon arrival to the emergency department with temporary newborn identification. Now, the emergency department staff nurse will be the one responsible to send the mother and the baby to OB/GYN emergency department with the temporary newborn identification. Now, the OB/GYN emergency department and NICU staff shall be responsible to complete the admission process for identification. Now, in case cesarean section, the identification is done by the NICU nurse and the pediatrician who attends the delivery. The newborn footprints taken by the NICU nurse and the physician. And after securing the newborn footprints, the mother will affix her left thumb mark on the form as proof that she acknowledges the identity of her newborn. Okay, now moving on to the second ESR of QM, we have QM 18. It states that the hospital has a process to prevent wrong patient, wrong site, and wrong surgery procedure. Substandard states that there is a process implemented to prevent wrong patient, wrong site, wrong surgery procedure during all invasive interventions performed in the operating rooms and other locations. Another substandards, the process consists of 3 phases: verification, site marking, and timeout. Now, a pre-procedure verification on the patient information is carried out including the patient's identity, consent, full details of the procedure, laboratory tests and images, and any implant or prosthesis. Another, the surgical or procedural site is marked before conducting a surgery or procedure. So this includes the site is marked, especially in bilateral organs and multiple structures like the fingers, toes, and spine. The site is marked by the individual who will perform the procedure. The patient is involved in the site marking process. The site marking method is consistent throughout the hospital. The site mark is visible after the patient is prepared and draped. A final check timeout is conducted before the procedure is initiated, and a timeout is conducted in the locations where the procedure will be done just before starting. Okay, so we have policies and procedures of our institution that supports QM18. So this starts with preventing wrong site, wrong procedure, and wrong person surgery. We also have surgical safety checklist and site marking timeout policy. Okay, now moving on to the policy of preventing wrong site, wrong procedure, and wrong person surgery. The policy states that all patients scheduled for surgery, regardless under local anesthesia or general anesthesia, must have a valid written consent. Now, circulating nurse must identify the patient correctly before accepting the patient for surgery. Now, confirmation of patient identity should always be done verbally for conscious patient, and for unconscious patient, fully sedated, senile, or handicapped, or children, patient identity should be confirmed through relative and guardian. Now, all patients entering OR must wear identification band at all times. All patients undergoing surgery must have a complete surgical safety checklist compiled. The surgeon performing the operation is responsible for marking the site and side of the surgery, and operating room surgical safety checklist should be practiced at all times. Okay, let's continue. Check the site marking done in the marking site form if it coincides with the site of surgery site. Recheck the surgical safety checklist if protocol is followed for patients undergoing surgery, and focus on this one. Do the in, time out in a timely manner. Okay, we will be discussing this with the other policies and procedure. Okay, moving on to the surgical safety checklist policy, we have here definition of terms. Surgical safety checklist, this consists of two forms. So the first form is the preoperative checklist, and the second is the verification marking and timeout documentation. Then we have here, they define the three phases. We have sign in. This elapsed period after the patient's arrival at the operating room reception and shifting the patient to the operating room waiting area. Then we have time out. This is the period before the induction of anesthesia, and sign out, the period during or immediately before wound closure or prior to removing the patients from the operating room. Okay, now we move on to the policy of surgical safety checklist. It states here that the coordinator of the surgical checklist is the circulating nurse in OR. The review of the checklist steps will be done verbally. The surgeon and the anesthetist should participate actively in the whole process of the surgical checklist. Now, the checklist is mandatory for all patients undergoing any surgical interventions under general anesthesia or conscious sedation inside OR or in setting other than the operating room. Okay, now for the procedure of the surgical safety checklist, I summarize it because I'm going to discuss again on this one in another policy. Now, for the sign-in with the circulating nurse and at least anesthesiologist, the checklist coordinator or the circulating nurse verbally confirms with the patient's identity, the type of procedure plan, and the site of the surgery. Now, for timeout before induction of anesthesia, the circulating nurse, anesthesiologist, and surgeons will again verbally ask each person in the room to introduce himself or herself by name and their role. And the circulating nurse will ask everyone in the operating room to confirm the name of the patient. Then finally, the sign out before the skin closure or the circulating nurse, anesthesiologist, and surgeon. The nurse will confirm the surgeon and the team for the name of the procedure done, and the scrub and circulating nurse will verbally confirm the completeness of the final instrument, sponge, and needle counts. Now, for our final policy, we have site marking timeout policy. Now, the purpose is to promote patient safety by providing guidelines for verification and ensuring correct site, correct procedure, correct patient for all invasive surgical procedure done in our institution. Now, for the definition of terms, focus on timeout. This is the final verification process before performing any invasive or surgical procedure for all procedures inside and outside OR. Okay, moving on to the policy of site marking timeout policy. Now, for all invasive surgical procedure inside and outside OR, now marking the procedure site is done so all staff will easily identify without ambiguity the intended site for the said procedure. Now, make sure that all relevant documents and related information, equipments are available prior to the start of the procedure, correctly identified, labeled, and matched with the patient's identifier. Now, timeout to be conducted prior to starting a procedure for final assessment for correct patient site positioning and correct procedure are identified. Now, in extreme emergencies like life-saving procedure, the circulating nurse will proceed to the sign-in and time-out while the team is preparing the patient and without delaying them for proceeding. The pre-procedure verification process is also conducted. Okay, now let's move on to the procedure of site marking timeout policy. So site mark is defined as marking the site where the proposed procedure or operation is to be done. Now, the site mark is required for all patients having an invasive or surgical procedure, including the bedside invasive procedure that involves laterality, could be left or right, multiple structures like fingers, toes, or lesions, and multiple levels like your spine. Now, for procedures that accept the site marking but still need to abide with the policy guideline, we have gastroenterology or endoscopy, tonsillectomy, hemorrhoidectomy, single organ cases. Now, for teeth, in case of teeth, the operative tooth will be documented in the patient's record or marked on the dental radiograph. Okay, moving on to the procedures for marking the site. Prior to marking the sites, the physicians performing the procedure, surgery, or verifies the patient's identity, consent, medical record data, including history, physical, and radiograph to confirm accuracy. The physicians performing the procedure surgery discusses with the patient to state the procedure, the site, and the sites of surgery, as well as the point of the site. Now, if the patient is a minor and unable to verify the information for his or her verification, so it must be identified with the parent and the legal guardian. Now, the site mark is completed by the physician performing the procedure the day before the patient enters the operating room or same day of the procedure for the day case surgery. Now, a site mark is made at or adjacent to the incision site. And remember, X mark is the only accepted mark for site marking. Okay, pre-operative verification. The verification is done when the patient is admitted or when scheduling is done for an invasive surgical procedure or when the patient is transferred or received at the operation theater. Now, the following information is verified when an invasive or surgical procedure is to be performed. Now, the patient, including the patient record, is checked for relevant information. So, the patient's four names for Saudi nationals and three names for other nationalities. And then the medical or the MRN or the medical record number, the procedure to be performed, the surgical site mark present, the consent for the procedure. Now, for any discrepancies, you have to inform the most responsible physician. Okay, now let's move on to the surgical safety verification is performed inside OR and it is composed of three phases. So the phase 1, we have sign in. This part is performed inside OR and it will be performed at least by the nursing staff and anesthetist and should include the patient must confirm his identity, procedure, and consent. Verification of the marking of the site of the procedure, verification of all machines and medications of the anesthesia are complete. Verification that the pulse oximeter is functional and connected, verification of the past history of allergy, difficult intubation, or risk of aspiration, and if the patient has any risk for bleeding for more than 500 cc or more than 7 ml per kg in children, and presence of 2 IV lines and preparation of blood or fluid should be checked. Okay, now let's move on to phase 2, timeout. This part is performed in the presence of the surgeon, anesthetist, and circulating nurse before induction of anesthesia, and this should include confirm all team members have introduced themselves by name and role, confirm correct patient, confirm correct procedure, confirm correct site, confirm correct site, confirm the correct patient position, confirm the availability of correct implants, confirm all the required laboratory results are available, confirm all the required equipment are available and functioning. Any critical event that could anticipate must be noted by the surgeon, anesthetist, or the nurse, such as non-routine steps, duration of the procedure, or any anticipated blood loss, as well as any specific concerns, sterility confirmation, and equipment issues. Now, the essential imaging availability must also be mentioned, and the approval of all team members must be documented. Okay, now for the final phase, we have sign out. This part is performed by the nurse before the departure of the patient from the operation room, and it includes recording of the name of the procedure, completion of the count of all instruments, sponges, and needles, labeling of all the specimen and reading its details out loud, and mentioning any special concerns by the surgeon, anesthetist, or the nurse for the recovery period. For the summary, based on our policies and procedure for QM17, patient will be correctly identified using two patient identifiers in the ID band. 4 names for Saudi, 3 names for non-Saudi, plus the medical record number. Now for neonates, mother with four names for Saudi or 3 names for non-Saudi, plus the baby's medical record number, the sex, the nationality, the date and time of birth. Now for the patient in ER without admission, they will be identified by their names and ID number. Now for QM18, the processes to prevent wrong patient, wrong site, wrong surgery or procedure, we have 3 processes. So the first one is verification, second site marking, and the third is timeout. Verification is this is correctly identifying our client using two identifiers and other pertinent information. Now for site marking, X is the only site mark or sign approved by our institution. Now for timeout, as stated in the site marking timeout policy, the surgical safety verification process that is performed inside OR composed of 3 phases. So we have phase 1, that is the sign in, phase 2, time out, and phase 3, the sign out.